It is November 17, 2020. And as of today, we have 6,899 cases cumulatively. We report 90 deaths, but I believe since this data has been pulled, there may have been 2 more reported in. I know there's at least 1. Active cases, 2,554, recovered 4,255. Case fatality rate, which is just a calculation of confirmed cases over time and deaths over time, 1.3%. That number's been kind of holding right in there for a while. And then all of this monitoring is really about contact tracing and identifying close contacts, making calls to them, letting them know they've been in close contact, getting them in quarantine, that sort of thing. TraceForce is the state, basically group of folks that we work with to do some really the majority of our contact tracing at this point in time. Hospitalizations at Sparrow and McLaren as of yesterday, 156 suspect and confirmed. Of those, 148 have been confirmed. A total of 15 of those folks are in the ICU, 16 ventilated. There were 49 emergency department visits in the previous calendar day, so the 15th. So that is still running in the 40 to 45% range, Ingham County residents of all of these people hospitalized. Hospitalization graph now looks like this since the beginning of the pandemic. So cases in April, hospitalizations in April, and then cases at this point in time. So an important thing for us to realize is that back in April, we had about this many cases, right? And we had hospitals that were full, and we were struggling with hospital capacity then. Now we have this many cases, and we are again full and struggling with hospital capacity. But from a relative perspective, we have lots more cases, and we're running about the same, hospital capacity thing. I think I have the graph coming up next. So that just gives you a sense of, while we are seeing this increase in hospitalizations and lots of hospitalizations as a relative percent of total number of cases, we are seeing that go down. So we do have the same number of hospitalizations and the same strain on our system as we did back in April, but we don't have the kind of, we have far more cases. So beginning August 4th, they changed the reporting system for hospitalizations so that we knew that who was hospitalized, who was ventilated, those sorts of things. But that started on the 4th. Before that, the reporting was very different. That was part of the federal DHHS change in reporting requirements. So we can only go back to the 4th with this graph, so you see what has been happening since August 4th, and of course, the clear increase in hospitalizations. Yeah, that's hospitalizations. Again, way more I got messed up talking about that. I was talking about cases. This is hospitalizations. We do, in fact, have way more hospitalizations than we did in April, but we also have way more cases. So sorry for the misspeak on this. I was talking about this as if it was cases. So again, hospitalizations in April, hospitalizations now. But if we look at cases now versus cases then, we also see a marked difference. And definitely filling up our hospitals now with things other than COVID as well. So we have 61.7% recovered, 1.3% deceased, and 37% of our cases are now active. So you see with the rapid increase in case numbers that, people are still recovering, but as a percent, we're now starting to grow in our number of active cases relative to our number of recovered cases. We saw that number in the 70-some%, not that long ago. Our cumulative case curve looks like this. We are definitely nowhere near a point of flattening this curve. So we are growing rapidly in terms of number of cases confirmed on a daily over time. And we were looking for this flattening, which we saw in June for a short period of time, and then started going up, and then just really have been increasing. We had that September increase that started to flatten a little bit, and then we took off again. If we look at our incidence curve by day, You will see again, yes, we do have lots more hospitalizations, but look where we were with cases in April versus cases now. So that would be fully expected. You can see now also, and we'll talk about this, you saw the press release yesterday about contact tracing and case investigation. We have days when we are getting over 200 cases a day here in Ingham County. So you can see this day in November was really approaching 250. Here we have, probably 210 or 20. Not uncommon at all for us to be in the 100 to 150 range per day in terms of number of cases. Our test positivity rate has been gradually going up. I told you for a long time, I'm comfortable in the under 3% range. We start to get 5%, and I'm a little less comfortable. We start to get over 5%, and that is not a good space to be in. The state cutoff for low trend, like kind of the low level of positivity is 7%. So we have exceeded that. We are running in the last few days in really the 9 to 12, 13, 14% range. Well, actually, it didn't get as high as 14%, so 13%. So if we look at that on rolling averages, so you won't see that 13% because we're averaging all those numbers together over 7-day periods. What you see is our positivity curve, which is on its way up, as well as our incidence curve, which is on its way up. So on a rolling average basis, even we're looking at about 150 cases a day on a 7-day average that are being reported into us at this point in time. When we look at the geographic distribution by zip code, we still see 48823 out ahead with 2,231 to 2,240. 48911 is rapidly increasing now as well. 921, 930 cases in that zip code compared to just a week or two ago, it was significantly less than that. I think it was more like about 400 or 500. So we are seeing a lot of our zip codes that we were seeing with high numbers of cases starting to rapidly increase, as well as the 48823 continues to increase, but more closely to the rate that is going on with the rest of the community. So we're seeing a little bit of a balancing out between 48823 relative to other zip codes. However, by rate and by case number and by every other metric we have, 48823 is still our highest zip code in terms of cases by population, by rate, followed by 48911 right here, and then 48912 or 5, this one is in here. Then we have our 48910, our Okemos, Hazlitt, Williamston, Holt, Leslie, these zip codes all at the next level down. And then the Lansing 48906, which is out toward the airport, as well as Stockbridge is our next level. Most of these other zip codes really don't have enough cases for us to really be very confident in what that rate would look like there. So if we look at a heat map, we still do see that significant number of cases in the 48823. But again, as the other cases start to grow, you are seeing these other spots. So this is that other zip code in addition to 48911 that was the next shaded one right up in here. And then we zoom into 48823 and what's going on there. And we do see this yellow blob kind of diminishing with, a little bit of the more red kind of creeping out from it. And then again, we still see these circles where we kind of see this concentric, kind of pink ring with the yellow ring on the inside. Again, those are apartment complexes where everybody with that address has the same address, even though they're living in multiple different, apartments throughout there. The street address is the same for all of them. Our cases are 50% female and 50% male. We are now 36% in our 20 to 29 age group, 17% in our 10 to 19 age group. So those are going down just slightly. We were at 42 or 43% and about 20% as some of the other age groups start to come up. So we're seeing that increase now in the 30 to 39, 40 to 49, 50 to 59, which is kind of where we saw, all of those age groups fairly even at some point in time. These age groups, 20 to 29 through 50 to 59, were fairly even across the board. we've seen this age group really come up, largely due to the 18 and 19-year-olds in that age group. And then, very low percentages on either end. Part of this is because we don't have as many people in our community that are over the age of 80 as we do here. So they're going to always represent a smaller percent of our total cases. But if you calculated a rate based on how many 80-plus-year-olds are in our community, you would see probably a little bit different kind of look here rather than just flat out percents. So when we look at cases by race, it's 62% Caucasian, 13% African American, 14% other, 5% Asian, 6% unknown. By flat out percent, we still see a little bit of difference in terms of, our Caucasians in our population are more in the 78% range here in Ingham County. So we are underrepresented in Caucasians. We're slightly overrepresented in Black and African Americans, 5%. When we go to look at the rate, this is about 1.3, 1.35 times more cases in our African American population by rate, in other words, by representation of population compared to our Caucasian population. And then now the Asian population is actually slightly less, as we see, more and more of our cases, especially in September and October, tended to be Caucasians rather than African Americans or Asians. And so that narrowed that gap for a while. We'll see as the trend continues and we have kind of community-wide transmission, whether that starts to change again. The outbreak that we had was kind of in a subpopulation that was largely by demographics, a Caucasian group rather than African American. Now, as we see community-wide transmission, I would anticipate that the disparities that we've seen across the country, across the state, and in this county early on will start to show themselves a little bit more again as we move on with this widespread community transmission. By ethnicity, 77.4% not Hispanic or Latino, 8% Hispanic or Latino, 14.5% unknown. So this is about 1.2-fold difference between the Hispanic and Latino population over our non-Hispanic and Latino population. So you do see that slight disparity there as well, where our Hispanic and Latino population is being impacted or has a higher disease burden than our non-Hispanic and Latino population. When we look at deaths by age, we now have one death younger than 40, and then so that's 1.1%, 2.2% 40 to 49, 6.7% 50 to 59. We've got the same shading in our 60 to 69 and 70 to 79, but I can tell you that 15.6% is 60 to 69, and then 33.3% 70 to 79, 41.1% over the age of 80. So we still do see a large portion, 74, 75% of our deaths in that over 70 age group. I will tell you, we put under 40 because we'd have to go down a couple of age groups. The under 40-year-old individual who died was male, 26 years old. Deaths by sex are 46.7% female, 53.3% male. By race, 1.1% Asian, 3.3% other, 22.2% African American, 72.2% Caucasian. Of note, within the other age group, typically that would be Native Americans, Pacific Islanders, Eskimos. Those populations are our typical other in terms of race. What we find is that on a death certificate, and I explained this before, on a death certificate, somebody who is Hispanic or Latino can list Hispanic or Latino as their race. In vital statistics demographics that we use in terms of public health demographics, census kind of demographics, I shouldn't say vital statistic because that is a death record. So in census demographics, Hispanic is an ethnicity and is not a race. And so when you have Hispanic population folks who do not easily identify as either being Caucasian nor Black, you oftentimes will see on a death certificate they will list their race as Hispanic as well as their ethnicity. We don't have a bucket for that within census statistics and the way we do rates and that sort of thing. So several of these others are Hispanic individuals who do not identify as either Caucasian or as Black. And the only place we can put them within the way that we do data is in this other category. So a number of those people are not Native American or anything like that. They are Hispanic individuals who do not identify as either Black or Caucasian. When we look at deaths by ethnicity, 90% of our deaths are not Hispanic or Latino, 5.6% Hispanic or Latino, 4.4% unknown. Still tracking MSU-related cases just by week right now. I'm not going to give you all of the full data related to that, because at this point in time, the outbreak that we saw, which was significant and preceded the increase in cases community-wide, did come down and level off. Now we're seeing this increase in cases, but we're also seeing an increase in cases across the entire community. So you would expect that as part of our community, cases would start to go up in the MSU-related population as well. So we're not seeing a specific cluster or outbreak or number of cases there that is drastically or significantly different from what's going on in the community, but we are seeing this upward tick in cases in our MSU-related and our MSU population as well. And I believe that gets us to the end. Before we get to questions on that, let me just explain the press release that went out yesterday about contact tracing, case investigation, and our strategy around that is really basically just understanding the principles of public health and the strategies and tools that we use in public health and what they actually can accomplish. And so when you talk about being able to identify cases, in other words, test, and then investigate those cases, so call them up and find out when their onset was, what's going on, what their symptoms are, get all this demographic information. A lot of the demographic information comes from the testing reporting, because that, of course, gets entered into the medical record. And then doing the contact tracing followed by isolation or quarantine are very, very effective public health strategies for outbreaks, for clusters, and for really more sporadic transmission in a community. When you have broad scale, just widespread transmission in a community, those are not the tools that we use. Those are not the tools, and we hate to use the flu comparison. Those aren't the tools we use during a flu season to try to contain flu. What we do during flu season is we ask people to wash their hands, cover their cough, stay home when they're sick, and know to be home so they don't infect other people. And so that's what we need to do now with COVID-19. We do during flu season investigate outbreaks. We have outbreaks in schools, we have outbreaks in nursing homes, we have outbreaks lots of places, and we also do focus on our more vulnerable populations. So again, widespread community transmission happens every flu season, lots and lots of cases of flu all around us. Right now, widespread community transmission with COVID-19. And so your effective public health strategies really need to be geared towards the things that they are effective in controlling and containing. And that is outbreaks, clusters, and then priority groups. So the places where we know people are most vulnerable and the age groups that we know are most vulnerable. So we're looking at our school settings and focusing on the college age group, as well as the K through 12 group. We are looking at, making sure that we investigate the 65 and older, as well as any outbreaks, any clusters. And then beyond that, prioritizing cases that have come in within the last 3 days. If they are more than 3 days old and don't fall into one of those categories, then it's not likely that people will get a call from the health department. But we are going to be sending out the information. I think the press release, I don't know if the press release included the couple of one-pager infographic kinds of things that we have available for that. But what we're really needing folks to do is to manage some of this to some extent on their own, as would happen with many other illnesses, just because of the breadth of what's going on right now. So, people have heard us, fortunately, through all of you for months now, talk about, when you get sick with COVID, you isolate from 10 days from onset of symptoms, or 24 hours after your fever resolves, and symptoms are improving if your symptoms last, up to or longer than 10 days. So it could be a longer isolation depending on symptoms. That is something that people can manage that. The other thing is we know how to identify close contacts now. Used to be we were kind of a little in the dark about that, but as routes of transmission got a little bit more clear and all of that, we do know that being maskless and within 6 feet of somebody for a prolonged period of time, 15 minutes, which can be cumulative over a 24-hour period, is what causes that high risk. So I will say that if you are wearing a mask and within 6 feet of somebody, or you're not within you're a little bit further than 6 feet with somebody and you're not wearing a mask, we're still going to call that a close contact. We need all of those things. We need mask wearing, we need distancing, right? Either of those two things are missing and that 15 minutes is there, that is going to probably still be a close contact because the other mitigation factors were not in there. So if we are closer than 6 feet and or maskless, and that period of time is 15 minutes, which can be cumulative, those people are your close contacts, and you can notify them. You tested COVID positive, and they need to quarantine for 14 days from the last time that you were in contact with them. So we're asking people to just reach out and do that. And so people know that they need to be quarantined. We will continue to focus our efforts on, again, the priority groups that we have identified. It is not a matter of just giving up, crying uncle, waving the white surrender flag or anything like that. It's just purely a matter of public health and widespread transmission. And the fact that the tools that we use to contain just do not contain at this level of widespread transmission. But we can focus on the areas where we can contain, where we can protect people, and we can focus on our more vulnerable populations and vulnerable groups. And so that is where we are shifting towards. As you can imagine, 250 cases in a day. There's a lot of people to call. And so there is a workload issue to it, but I will tell you that we could add enough staff to be able to call all 250 people every day and to be able to get a hold of all of their contacts on a regular basis. And it still will not contain widespread community transmission. So it is not just a matter of just add more staff so that you can do it all. It's just not an effective strategy when it's out there in the context and in quantity that it is right now. So that is very much the reason for our shift, to focus on that and to continue to educate the public in terms of what they need to do. We can email people. We usually have emails or something like that. We could probably, a lot of times we have their phone numbers. We can text those infographics, stuff like that. But we'll be working on getting that information into the hands of people so that they know what to do. And there you go. That kind of explains what happened yesterday with the press release, because I know you guys were going to ask me questions about that.
Thank you, Linda. Does anyone have any questions for Health Officer Vail? Go ahead, Megan.
So you said it's not concerning to see cases going back up at MSU because it is just kind of part of, widespread community transmission. But I did notice the numbers of tests coming out of MSU were a lot higher. Do you think that's just part of people going to get tested because there is transmission, or is there something else behind that?
I think that's just people going to get tested because there is transmission. And of course, they're testing many athletes on a regular basis as well. And I will say, at this point in time, what's going on with MSU kind of parallels what's going on in the community. That's not to say that in the next few weeks, we might not start to pick up another, cluster or something like that there, and we'll continue to monitor that and work with it. But right now, I wouldn't call it anything other than it's trending up, just like everything in the community is trending up. And testing is increasing across the board. And they are doing quite a bit of testing on site at campus. And so there's an accessibility issue as well, in terms of students really having good access to an accessible testing place right there nearby.
Okay, thank you.
Emily Joan Elliott, go ahead.
Great, thank you. I had read in the Detroit Free Press today that Sparrow was nearing 81% capacity, and I was wondering if you could speak to staffing and PPE levels at our local hospitals, if they're reaching kind of a critical phase right now.
You know, I didn't go on to EM Resources today to look at PPE levels. Last I knew, PPE was holding on just fine. We are seeing at this point in time, just because we're seeing widespread transmission in the community, we're seeing more healthcare workers also get sick, more other people get sick. So, and then, there are times, typically we try not to quarantine healthcare workers. We just, they've been exposed. They're going to be exposed due to the nature of their work because they're taking care of patients. But if that exposure is like a family member, so if a healthcare worker is living with a family member who is COVID positive, then we do need that person to quarantine because that exposure is ongoing and continuous and does place, there's no way to just kind of mitigate that risk by just continuing to put on PPE at work because of a single exposure rather than ongoing exposures. So as family members and stuff like that become ill, we're seeing quarantine for healthcare workers as well. I was on a brief Zoom meeting with CEO Jim Dover yesterday, and I think they're struggling with some staffing issues. They're definitely reaching capacity. If you look at that graph, it does look like maybe they're leveling off just a little bit. I hope, So I think they are opening up some beds at Sparrow St. Lawrence campus. So I think they've added maybe around 15 to 20-ish beds over there as well, or they're in the process of doing that. So it really is going to be better for my healthcare partners to talk to you about what's going on with their capacity and their staffing. Unfortunately, when they changed the reporting requirements within the system, what they got rid of for me as a person just kind of looking at it was total bed availability. So I no longer can see going into that system, Sparrow has X number of beds and this many are full and this many are full with COVID patients. All I know is their COVID census and the number of COVID patients in ICU, the number of COVID patients that are on ventilators. I can see some PPE availability, how long they anticipate their PPE holding out and things like that. But I don't have a good way other than asking my healthcare system partners themselves to evaluate where they are with regard to total capacity, because I can't see total beds and total hospitalizations anymore. All I see is COVID.
Sure. And a quick follow-up is when you say the changes in reporting, you mean the federal reporting in August?
Yep, I do.
Okay.
Yeah, and that's why you see that basically that graph of ours that starts August 4th. That's when the reporting requirements changed. And in some ways, it gave us additional good information. So before, what I would see is there are this many people in ICU and we have this many ICU beds. I didn't know how many of those patients were COVID patients. I just knew what was going on in ICU. Same thing with ventilators. I had a total number of ventilators in use. I would see total beds occupied, and total COVID patients. So really, and that's why the other graph we have, it just shows you the total hospitalizations of COVID patients, because at that point in time, that's what we knew COVID related, was just total COVID patients. We didn't know how many ICU patients were COVID or not. So that new reporting requirement helped us in some ways, but did take away my ability as a health officer who has access to that system to really get a feel for where we are with hospital capacity, other than just knowing that, COVID hospitalizations are soaring, which kind of gives you an idea that we're pushing capacity. Mm-hmm. So that's going to be a question you're going to have to ask the health systems.
Sure.
Dave Ackerley, go ahead, please.
Hi, Linda. One thing we talked about months ago was expanding testing, and that was done to a high degree, especially with Sparrow's drive-through, to the point where they were inundated, and then said here a week ago they were having a hard time getting results back quickly. So they've gone now, they're going over to if you're not symptomatic, an appointment. Now, some people may say, great, I'll make an appointment. Others may say, never mind. Do you have any concern that could give us a false picture, maybe less positive tests, maybe that number of daily positives goes down, but it may not be an accurate picture of what COVID is in our community right now.
So, no, I don't have a lot of concerns. I mean, Sparrow's capacity to test is going to be their capacity test. We have MSU Health Team testing. We have other places testing. Urgent cares are testing. We have testing going on in some of our pharmacies. They're starting to bring in some of the antigen testing as well, which is good for antigen testing is particularly useful if somebody is symptomatic. So if somebody is symptomatic and tests with an antigen test, because there's false positivity, false negativity issues with an antigen test. It's not a confirmatory test. But if somebody comes into an antigen test with all of the symptoms of COVID, and then that test comes out positive, what you say is your pre-test probability was high. And so now we have a test result that agrees with that pre-test possibility. And so we're not even going to do a confirmatory test. We're just going to call you what we call a probable case, and we're going to go with that. But I also want to clarify what's happened with Sparrow and their requirement for an appointment. That was mostly about efficiency so that people were not in these lines for so very long. So what was happening is people were arriving and registering and all of that sort of stuff, getting information while they're coming through lines, and that slowed everything down. The appointment process allows them to gather that information ahead of time. So while it sounds like a barrier in the sense that, oh, I have to have an appointment, I have to get a hold of my doctor has to decide whether I get a test or not. What was explained to me is there's still a way to get into the system, the portal, whatever, to schedule a test and to get that, order. It's not prohibiting people from still going to get tested. It's just a matter, it's kind of almost more like a pre-registration process that's going to help with their throughput. So that strategy was really more about efficiency and throughput than it was about shutting down the amount of testing that was coming through so that they could limit that and do a better job of maintaining capacity. So I'm sure John Foran can explain it to you a little better than I can, but I did get their press release ahead of time, and I did talk to John Baker, who is with their laboratory system, and that's kind of how it was explained to me. So we need to make sure people understand that they still can get tested. They just need to use Sparrow's process of going in and registering for that, and then that will create that order that will allow them to come in and also manages that throughput a little bit better, because a lot of the information they were having to gather by people just showing up was slowing down the process.
Cool, thank you.
Mm-hmm.
Kyle Kaminsky.
Hi, Linda. Regarding the latest orders on the number of households that are able to commingle under the same roof, I'm curious, how do you expect that to translate to enforcement at the local level? And how much of this is really about personal accountability as opposed to dispatching the crowd control police, so to speak?
The crowd control police have never been basically knocking on the doors of people's residences. So that said, it really is about personal responsibility. There's an order in place. You can gather in a household 10 people, no more than two separate households. But it's really not a very easily enforced order when it comes to people's homes. I mean, Kyle, I don't know how many people are in your home any given night, or how many people from how many different households, or any of the rest of you, nor do you know what's going on in my home. So, we just hope that people understand the severity and the magnitude of what's going on right now, and take that order as a strong recommendation to do the right thing, and that they do the right thing. And to some extent, it will get the attention of some people, and it will get ignored by some people. It's porous. It's always been porous. All of this has been fairly porous from the beginning. But in the end, it gives us incremental gain, which is better than doing nothing.
Thank you.
Mm-hmm.
Scott Pohl.
Hi, Linda. I wanted to ask you a pretty overview type question about the new state rules that are taking effect tomorrow, and your observations about them. Do they go far enough? Are there things you wish were in the order that aren't? Can you comment in general on the new state guidelines?
Well, first of all, we have to realize that the epidemic orders under the authority of the public health code are never going to be as broad as the executive orders were. The code is very specific and requires very specific definitions and very specific demonstration of certain things in order to justify those restrictions. Which clearly, with the amount of COVID that's going on right now, the data supports that. I do think that it was a little more targeted, a little more surgical. In a lot of ways, it got at the things that over time we have discovered are the more problematic situations. There was an article in the Chicago Tribune not long ago, I think maybe just this last weekend, just a few days ago, that talked about the fact that I think they were saying that about half their positive tests were people who reported had gone, out to dine indoors in restaurants and bars at some point in time, half. So we know, and it's unfortunate, we don't want to see any of our businesses having to struggle again. So hopefully this, kind of surgical precise thing with a limited time period gets us to a point where we can, kind of plateau here and start to get things pointed in a different direction. And it left open the things that we're just not seeing places where there are problems. It left open gyms, it left open salons. We haven't seen outbreaks or cases associated with those places. It left open K through 8 and closed down, high school. Again, there are reasons for that. The context of the way things work in high schools and passing time and changing classes and all of that creates a lot of mixing rather than, the younger groups, which tend to be a little bit more kind of almost like in their own pod. So those are easier to control. You're seeing some schools decide to go ahead and go full virtual anyway, despite the fact that the order clearly said that K through 8 was okay to stay open. One of the other things it did was it shut down the athletics. And I will tell you, that has been a huge problem. We've seen, more cases associated with athletic-related activities in high schools and junior high schools than we have really in classroom settings. And so that's been something I've been struggling with in terms of, watching athletics continue while we have schools going virtual and watching cases come up, on a routine basis related to athletics. So seeing athletics get pretty much shut down, I believe, was a good thing. So, in general, I think it was, I think, we're looking at a little bit more surgical precision and preciseness based on the data and information we have now, this 9 or however many months into this pandemic that we are at this point in time. And I think that, there will be close watching of what's going on. And during this 3 weeks, if things aren't, at least flattening or, starting to not be such a steep upward curve, if we can at least see that curve start to come down, so it's not so steep, then we can see that we're making some progress. If that doesn't happen, you might see maybe a revision of the order that would add other things. I don't know. And certainly at the end of 3 weeks, if we aren't seeing, that line at least start to not be so steep, we might be seeing the state have to consider extending that order. We certainly hope not. So, we would like for everybody, and I've told you all so many times, it's like, the bottom line becomes, we've got a handful of things that we ask people to do. And to some people, it feels like a sacrifice. To others, not so much. It doesn't really bother me so much to wear a mask when I go places. It doesn't really bother me so much that, capacities in places are restricted. So, other people don't feel that way about it. But the bottom line is that we're asking for people to do that for a very brief period of time. And it does work. And if we could get really good, solid adherence across the board by people in general, by just deciding to do the right thing, then we wouldn't have cases soaring and we wouldn't have to issue orders. So that personal responsibility thing is huge. We keep trying to let people know that we wouldn't need orders and we wouldn't need restrictions if we could count on people to do that handful of things that we really need people to do. But it's not happening. And so we continue on this path of orders and restrictions and trying to use public health measures to get something in control. that we can't get the full cooperation of people. When I was on that meeting with Jim Dover yesterday, he made a good point about, his father was, of the greatest generation and had fought in World War II. And that was a long period of time, and that was a long sacrifice by a lot of people. Those were soldiers that went to war and risked their lives. Many of them died. They were families that weren't together, that lost loved ones. There were people here that stayed on stateside in this country that got diverted into workplaces, that got repurposed to do all kinds of other things. There was a lot of sacrifice for a long period of time. We're asking people to sacrifice a whole lot less than that for a whole lot shorter period of time to save some lives.
Thank you.
Mm-hmm.
Rachel Sweet, go ahead, please.
Hello, Linda.
Hey, Rachel.
Can you kind of talk to the vaccines? I know that there'll need to be a freezer to hold the vaccines before they're distributed. Can you talk to, are any local counties in our area getting these specific freezers? Do you know?
Yeah. First of all, it's to all of you who didn't work in laboratories half your life. It's like, oh my gosh, it's a special freezer. Well, every laboratory I ever worked in had at least 2 of those special freezers. And every laboratory I ever worked in was on a hallway with multiple other laboratories where there were at least 1 or 2 of those freezers. And sometimes in the hallway were a few others that we all shared jointly. So it's not a rare commodity in the laboratory. Unfortunately, because in laboratories we use metrics, I can't give you the Fahrenheit, but it's a -70-degree freezer. Your typical freezer, in your house is a -20-degree freezer, and your refrigerator is 5 degrees. So in laboratories, we have 5-degree storage, we have -20-degree storage, we have -70-degree storage, and then we have liquid nitrogen storage. So yes, we have availability of those freezers. The state has been working to deploy a few of them to some of the larger counties. And then, I had a colleague, for example, in Allegan County, not being one of the larger counties, who was like, how am I going to get one of these freezers? It's like, call Paragon down the street from you. They're laboratories. They have them. Trust me. So we just need to figure out where those partners are and where those freezers are. If some people are buying them, some people are working with the state through the state acquisition system to acquire them. They are getting deployed across the state, or people are figuring out where to find them. And like I said, every place where you have any preponderance of research laboratories like MSU, no doubt in their biochemistry department and microbiology department and every other science department in their basic laboratories where they do research, have many of these -70-degree freezers.
Awesome. And then going off of, the order that came out and starting Wednesday, can you talk to restaurants and what they're going to have to do, what people need to know about either when they're going to restaurants or what business owners need to know during the 3-week?
So indoor dining is closed. So that's what people need to know about bars and restaurants. We're back to takeout and curbside. So there will be no indoor dining for 3 weeks. You can do outdoor dining. It's Michigan. So it's cold. And then if you start to think about things like, well, what about there are these igloos and other kinds of things. There was a Q&A by the Michigan Restaurant and Lodging Association that came out, and when the state made the announcement, at least to us on Sunday, when they announced us shortly before they did the press briefing on Sunday, some people asked about, what's considered indoors when you put a tent or an igloo or something else like that outdoors. So one of these igloos is considered indoors, and it can be used, but you can only put 1 household in there. The tents are considered indoors unless they have 3 flaps open. So you have to have, of the 4 sides of the tent, 3 of them must be open for it to be considered outdoors. Any more flaps than that closed, and it is considered indoors, not outdoors. So you could have a tent with a roof over it. You have 1 side down. I guess you could put some heaters in there or something like that. So that's the only way you're going to create outdoor dining right now, because igloos, tents, anything like that, that are not basically open on 3 of 4 sides are considered indoors.
Awesome.
So that's what we're doing. We're takeout, we're curbside, and bars and restaurants are in that mode as we were during the shelter-in-place order for the next 3 weeks.
And then one last question. There's a lot of rumors going around on Facebook that tonight, since starting Wednesday, might be the biggest bar night of the year, or people are going out. Can you kind of talk to that? Are you a little worried? What's kind of your thoughts there?
Well, that's unfortunate is what it is. I think, actually, I think Mr. Haywood asked me that question or made that point to me earlier today. And it's like, I don't, first of all, we're at 50% capacity or 125 in Ingham County. So we're still going to adhere to and require no more than 50% capacity, no more than 125. We're still going to follow all those other rules that were in place leading up to today, which means you have to wear a mask unless you're seated and eating or drinking, no more than 6 people at a table. You cannot get up and be anywhere else without a mask on. You can't congregate in dance floors or any of that sort of thing. You can't go and do bar service. It's table service only unless there are actually chairs at the bar. So all of those things are still in place through tonight. And then tomorrow, bars and restaurants will go to no indoor service.
Thank you.
Brittany Flowers, go ahead, please.
Hi, Linda. Can you hear me okay?
I can.
Okay. I just wanted to ask you, I know you talked a little bit about enforcement. I guess in terms of businesses, if there's something that someone sees that they know is not allowed under the epidemic order, is there somewhere they can report it or somewhere they should report it?
Yeah, we have an email address. We get all kinds of complaints through it. Sometimes I just get them straight to myself, but coronavirus@ingham.org is where you can send complaints. And we do follow up on them to the extent that we can. I will tell you that of the places that it is easiest for us to enforce, restaurants and bars are one of them, because as a health department, we license restaurants and bars. If we don't issue them a license, if we find a problem with their actions or breaking rules or not doing things in compliance with whatever, then we have the ability to close them down. We have the ability to bring them in for informal hearings or formal hearings. To the extent that it gets egregious, we have the ability to suspend or revoke licenses. And so as a health department, restaurants and bars are some of the easiest places for us to enforce closures or requirements, because we do license them, we do inspect them. We have a person on our staff that has a relationship with every person in charge at a bar and restaurant, because they go in and they do their inspections twice a year and they get to know those people. So but that is one of the easier things for us to deal with in terms of enforcement and ensuring closures really truly become closures.
So should people not contact local authorities, local police, or should they still?
I don't know that people have been contacting police very often. Most of the reports come to us. Even before, I would get a report of something that was open that shouldn't have been, so the complaints were coming here, and then I would get in touch with the prosecutor's office to get a hold of the proper law enforcement agency. So I don't know how many complaints were going directly to law enforcement, because it seems like most of them are coming to us. So probably most effective to get that complaint to us, and then we will handle it. Like I said, right now it's largely bars and restaurants. There are probably a handful of other things that are kind of listed in that closure list that I would start to have some concerns about, because we had some issues there before. We had some issues with some things that decided that they were just going to open up despite the fact that they were closed, and getting them closed back down was hard. But those weren't places that we regularly interact with, regularly enforce, and hold their license. And so it was a little bit more challenging for us. So, we will continue to do that, and we will continue to work with our law enforcement partners. Keep in mind that the city of Lansing, as well as the city of East Lansing, passed ordinances that made the violation of a public health order, either a state order or a local order, a violation of an ordinance. And so law enforcement agencies are able to go out and issue civil infractions for violations of this order fairly readily.
Thank you, Linda.
Or at least those two law enforcement agencies. There's another process for the rest of them, but I don't need to bore you with the complications of that. So.
Okay, thank you.
Scott, go ahead, please.
Hi, I just wondered if there was any update from the jail in terms of positive test numbers or if there have been any hospitalizations.
I've seen no hospitalizations. Most of those cases are asymptomatic, as the sheriff said yesterday, mildly ill. Last I knew, the numbers were actually down, either people recovering or people being, released, that sort of thing. I don't know if we released any positive cases though. So as of yesterday evening, when I talked to Major Southworth, who is the jail administrator, I think they were down to about 53. But we will be doing more testing. I think it's important to continue testing out there, to continue to identify cases and make sure that we do the best we can of keeping things as much as in control as we can. It's really, I mean, you'd think it'd be easy in a jail in terms of, like we identify these cases and it's like, okay, we'll just put all the positives over here, we'll put all the quarantines over here, and then we'll leave all the others over here, because they do have different pods and that sort of thing. But they have people of various security risks, and they have people, and so they can't commingle that together. And then they have people who, I learned this when I went out and did a tour of a couple of jails in Massachusetts back in December as part of an opioid project, that there are certain people in jails that they have to keep apart. They actually know each other, or might be gang members together, or things like that. And so it's like this person and this person can't be anywhere near each other. So there's lots of complications like that in a jail that don't make it as easy as you would think it would be to just say, okay, we tested you, you're over here with all the sick people, you are a close contact, you're over here with all the quarantine people, and the rest of you over here. So it's a little bit more tricky than one would automatically think.
Thanks.
Mm-hmm.
Emily Joan Elliott.
Thank you. I had two questions, if I can. The first was to see if you were able to say about the 26-year-old male who passed away, if he had any underlying health conditions.
Yes, he was actually had a disability, so we are seeing that as well. If you look at the statistics nationwide regarding people who are, burden of disease, people of color, and there is some evidence too about the disabled population and increased burden of disease there as well. Other than that, honestly, I don't know the rest of that. This case came into us through the medical examiner's office. So it was detected on autopsy that he was COVID positive.
Okay.
So
and
we're
then
still waiting. We'll have to wait. So we don't have like a clinical record. We didn't have him in our disease surveillance system. So we have to wait for the medical examiner to finish his autopsy report before we will have any of the other basically clinical history to the individual. So other than that, there was at least one other underlying health condition, and so that's what I know about that.
Sure. And then to follow up on vaccines, I know you had said last week that there's local plans in play for distribution, but I was wondering if you if there's concerns or optimism in dealing with the state and federal agency, but like how would the process look before it gets to Ingham County?
I don't know. That I don't know. I do know that, they're basically looking for capacity in terms of allocations. I think the first allocation that would come to the department, I think I heard on the meeting I was on last week, might be only like something like 900 and some doses, which is not a lot. But keep in mind, they're deploying out to hospitals to get healthcare workers vaccinated. They're deploying to pharmacy and pharmacy partners to partner up with long-term care facilities and get long-term care, both staff and residents vaccinated. Those are the top two priorities. Vaccine that will come to us will go, really our staff as well are going to need to get vaccinated. And then we'll start to go from there. So I think what you're going to see is the vaccine getting released in smaller allocations until we build up and get the priority groups vaccinated first, and then it'll be more broadly available to the public. I see that as probably the limiting factor in terms of how quickly we can get the broader public vaccinated. It really is going to be slowed down more by vaccine availability since it's coming out to us in lower allocations in the beginning than it is going to be about our capacity to vaccinate. I really do think that, with the number of pharmacies that will be involved, the number of healthcare providers that will involve, health departments, et cetera, and once the vaccine's available, it won't be problematic to get people vaccinated in a fairly short period of time.